buenas tardes a todos. Bienvenidos una tarde más aquí a los webinars de la SERVEI, del grupo de la ERF. Esta tarde vamos a tener una charla sobre criablación en el pulmón, que nos la va a dar el doctor Tarik, que trabaja, es adjunto en el hospital, en el Cancer Institute de Netherlands. Thank you very much, Tarik, for accept our invitation. Él habla un poco de español, probablemente puede empezar un poco la charla en español, pero la mayoría la dará en inglés. Recordaros que siempre podéis hacer preguntas, las podéis hacer en español, nosotros se las traducimos o directamente en inglés. Espero que disfrutéis de la charla y que os guste mucho. Tarik, whatever you want.
Primero, gracias para la invitación. Mi nombre es Tarik Baetens y trabajo en Holanda en el Instituto de Cáncer junto con también con Fernando Gómez Muñoz. El tópico de mi presentación es criablación de los pulmones. Originalmente yo soy de Curazao, una isla pequeñita en el frente de la costa de Venezuela, y entonces he tenido español en clases por muchos años, pero tengo muchos años sin practicar. Voy a probar intentar hacer la presentación en español, pero si va mucho lenta, voy a cambiar al inglés. Primero vamos, ¿cómo trabaja criablación? Trabaja con el efecto de Joule-Thomson. El efecto se describe que pasa con si hay expansión de gas y en la aguja de crío el gas se entra en presión alta y después entra en cámara de expansión. Y lo que pasa si la temperatura de inversión del gas es más alta que la temperatura ambiente, tienes enfriamiento, y si es más baja, tienes calentamiento. Y el gas argón te da congelación o liquid nitrogen también, y con helium se usa para calentamiento. Hay diversos vendedores de máquinas de criablación. Esos son algunos, y aquí también ves qué usan. Pues pueden usar argón y helium para calentamiento o solo argón. Y también tienen una más nueva con liquid nitrogen. Pero ves que las agujas son bastante grandes con este sistema. Nosotros tenemos el Visual Eyes y tiene una bobina eléctrica en la aguja para hacer el calentamiento. Y entonces solo necesitamos argón y no tenemos que comprar helium. Con temperaturas bajas, entre 0 y -20, hay hielo extracelular. El hielo extracelular puede hacer daño a la célula, pero no necesariamente es letal. Y algunas células van into apoptosis y algunos también quedan en vivo. Y también hay isquemia, pero eso también no es necesariamente letal. Pues lo que queremos es que la temperatura sea menos de -20. Y entonces hay formación de hielo intracelular, y este proceso es letal. Y lo que pasa es cuando hay calentamiento, el hielo intracelular va a, ¿cómo dice? Share the membranes of the cell y es letal. Lo que es importante también que es cuando vemos al bola de hielo, lo que vemos es el exterior y esos 0 grados, pero no es menos 20. Y pues el 5 milímetros que ves afuera no es letal. Aquí voy a cambiar por inglés. Here you see the table which we use to plan the ablations. So you can see the different isotherms for all the different needles, and if you use more needles, how big the ice ball is gonna get. These are the different kind of needles you have. Which is important that in contrary to cryoablation in other locations, in the lung, we always do a triple freeze protocol. The reason because of this is because the conductivity in the lung is very bad because of the air. So what they eventually saw in this article is that here the freeze cycle of 10 minutes freezing, 5 minutes thaw, 10 minutes freeze. And in the lower, you see 3 minutes freeze and thaw, 7 minutes freeze and thaw, and then 5 minutes freeze and thaw. So in total, 50 minutes of freezing in the lower table in B, but you see the ice ball already after 6 minutes. If you see in the longer freezing cycle, you nearly see an ice ball. So what they concluded is that you get a bigger ice ball in shorter time, and the ice ball is better visible. And this is because of after the first freeze cycle, after 3 minutes, you start the thawing, you get bleeding or edema, and then you get an increase of the conductivity of 20 times bigger. So this way you achieve a bigger ice ball faster with the second freeze cycle. Something else is that this is another article by Lyons. They looked at the ablation zones after one month. They say, well, after 1 month, all the bleeding is gone. There's no scarring, and they look at the sizes from the ablation zones, and what they see is, well, that the ablation zones are significantly smaller than the in vitro isotherms published by the manufacturer. So right here you show you this is what the red circle is, what the actual ice ball was, and the black is what you would have suspected to get. So what they say is, well, be cautious. It's better to use more needles in the lung. And then they give this table, well, basically saying that if you have a lesion from a size of 13 millimeters, and you want a 5 millimeter margin, you already need to put in 2 needles. And this is based on 17 gauge needles. So what I do is that I always try to use 2 needles as a minimum, but we'll get to that. Well, what kind of imaging equipment do you need or guiding? We do all the procedures by CT. You have an excellent contrast, but you have to put in the needles in plane. You get a better visualization of the multiple needles together and the distance between the needles. And I think you can better control hydrodissection and iatrogenic pneumothorax in contrast to CBC. a cone beam CT. But with the cone beam CT, you can put the needles out of plane, so that's easier. And well, in case of bleeding, you could treat directly, but I must say, in all the cases we've had here, I never had to treat a patient for a lung bleeding after a cryo. If we review the techniques, the contraindications, there's only one absolute contraindication. It's untreatable coagulopathies. But if you look up this article, it's by SERVEI, Standards of Practice. They give some relative contraindications. And this one here, lesion located less than 1 centimeter from hilum or large vessel. This is, in my opinion, really for RFA or microwave. For cryo, this is not a problem. You will still have, of course, the heat sink or the cold sink. So maybe, but it's not that dangerous. First, I always measure the lesions all in X, Y, and Z axis, and always look at it, well, is the lesion taller than wide or wider than tall? Why? Because I will use this to put in my antennas. You can stack them on each other or put them in the same plane. So furthermore, if possible, try to follow the longest axis of a lesion. This would be the 50 millimeters in this case, because the cryo, the ice balls are always a little bit cigar-like. They're not totally round. So you would match the ice ball better to the size of the lesion. Well, bracket the lesion, so use a minimum of 2 needles. And what I do to be sure of having my ablation margin is that I calculate on a -40 isotherm in the lungs. In other organs like kidneys, I go for -20, but in the lung, I go for -40. So in this case, with this lesion, you would say, well, we put in the ideal, you would put in the needles like this. You follow the longest axis, but then I need to go to the fissure, and I rather don't do that or have a long trajectory with bigger chance of bleeding. So we did it like this. 2 needles. Something else what's important is that the eyes distally of the needle eyes is only 4 millimeters. So you always need to extend the needles beyond the lesion. Check the needles in a different plane to be sure that you have a good contact with the lesion, because in contrast to RFA or microwave, it's all about connectivity. So you need to have contact with the lesion. Furthermore, it's always important to know your anatomics, be aware of critical structures. The most critical structures are all nerves. I would really encourage you to look up this article. It's really nice. And it shows you all the different location of the phrenic nerve, nervous recurrence, and vagus, which you don't want to damage doing a cryoablation. In needle placement with peripheral lesions, always try to put in the needle parallel to the pleura like this. The reason because is that you want to have some normal parenchyma between the ice ball and the pleura. If you freeze the pleura, you have a bigger chance of getting a hematothorax after removing the needles. So 2 needles parallel. If you also try not to avoid needle placement toward critical structures. So if you would need to treat a lesion next to the aorta, then you would come parallel and not perpendicular to the aorta. Anesthesia. What I normally do is we have general anesthesia with a single lumen tube. We do a tube disconnection, and then we do the planning with a fast-find grid. I will show you some examples. We mark the skin, and then every time we'll ask for a tube disconnection when doing needle placement. And now we also have general anesthesia with dual lumen endotracheal tube. I do this in patients which I will need to put on in lateral position, and I'm afraid of getting bleeding in another lung. Other options are general anesthesia with high frequency jet ventilation. The lungs will also stand still, and this is perfect for targeting the lesions and needle placements. Other options are conscious sedation with local anesthesia or regional anesthesia, which I would not recommend, but there are some articles doing that. What about positioning? I think there's a preference for putting the patient prone or supine. It's more stable and you have more space in the CT gantry. But what I do is if I have more lesions and I want to treat them at all, I'll just choose the best position so I can put in all the needles. Like this patient had 3 lesions. So I'll put the patient in lateral decubitus position with a vacuum mattress, but you will have less space in the CT gantry to put in your needles. You see the different needles put in, and this was the fast-find grid. Sorry, I didn't. Over here you see it. So you can mark the skin and then exactly know where you need to put in the needles. The freeze-thaw cycle we use is 3 minutes of freezing, 2 minutes passive thaw, and 1 minute active thaw. And then the same with 7 and 10. But there's totally no consensus about the freeze-thaw cycle. I think most clinics will have a longer thaw, but we just choose the shortest one to be, because it takes, the already takes a lot of time, in contrary to RFA or microwave. We make the CT, a control CT, 5 minutes in the second freeze cycles and 8 minutes in the third freeze cycle. Complications. Well, bleeding is one of the important complications you can get after cryo. This is a patient, 42 years old, rectal cancer, had laparoscopic resection. After 1 year, liver mets, 1.5 years later, lung mets, got radiotherapy. 2 years later, again, lung metastasis in the right upper lobe and right lower lobe, for whom he got radiotherapy, and then he gets an infield recurrence. So we just discussed the patient in the MDT and say, well, let's do a cryo. This is the lesion, 20 to 22 millimeters and 25 cranial caudal. Put in three ice force needles. And here you check the other plane. I always check the distance between the needles because the distance is too much. You will get separate ice balls, and if you place them too much near each other, you will get a very small ice ball. So after removing of the needles, we already get bleeding. It's also in the main bronch, and so we directly change the patient. But you can see there's a lot of blood, and there's also blood in the other lung. So this is a case from 3 years ago. If I would do this case again, I would do it with a double lumen tube. So you won't get bleeding in another lung. Eventually, the problem was with this patient that we could not get out the thrombus. So they could not ventilate him well, and they had to take it out with a rigid bronchoscopy. And after that, he recovered well. Another complication, of course, is the pneumothorax. What I do is I make, after removing the needle, I directly make a CT scan. And 5 minutes later, I repeat it. If there's a small, non-progressive, small pneumothorax, I won't do anything, or sometimes just aspirate it with a 21 gauge needle. If it's a progressive or large pneumothorax, of course, we'll put in a chest tube. I always take out the locking wire of the pictal drains, because there's a chance that when the lung you don't have a pneumothorax again, the wire of the drain can get around the lung. And if you take it out, you can lacerate the lung. So I always take out the locking wire. We attach a pump with a pressure of -12, and we make an X-ray on the recovery after 1 hour. If there's no air leakage, I will put it to -8. And the next morning, if there's no air leakage or total production less than 400 cc, we'll make an X-ray, and after that, if it's okay, no pneumothorax, we'll take it out. Take the chest tube out, observe the patient for a couple of hours. And after that, they go home the next day. I have some cases you can look at. First case is a male, 74 years old, with a clear cell renal cell carcinoma, Foreman grade 3. He had pleural mets, and then got a cytoreductive nephrectomy, and he got the spontaneous regression of all his mets. Something we don't see often, but very good for the patient. And 2.5 years later, he had a progressive solitary lung metastasis with satellite. You can see a small, looks like a small satellite lesion or small lesion next to it. And well, we decided we'll do a cryo. It's the craniocaudal. You see the small extension here at the back. So we put in 4 needles, and I want you to look at the small nodule at the back, because this is important for this case. You see there's contact with the main lesion, but not with the small lesion at the back, and there is air around it. This is the follow-up after 1 month. With reactive pleural effusion, we see that a lot. We don't do anything about it. It will reabsorb. This is after 3 months. And this is after 6 months. The small nodule growing here at the back. I think personally it's the location of where the nodule was, and there was not enough contact with the needles. So the takeaway message, always be sure that there is contact with the lesion, good contact with the lesion. We ablated it with a new wave PRX. They did a microwave, and now the patient is for 3 years recurrence free. Case 2, patient 57 years old, colorectal cancer, had laparoscopic resection and chemo. After 3 years, local recurrent disease, got again resection, and then lung metastasis in the left upper lobe. And you can see it's very central near the vessels. So we discussed the patient in the MDT. They didn't want to do radiotherapy, and we decided to go for cryo. So this is what I was saying. Normally, you wouldn't want to put in the needles perpendicular to critical structures, but in this location, I didn't have any other options. So we did it this way. Of course, you will have your cold sinking here and a bigger chance of recurrence. Check the other plane for the contact with the lesion. This is the third freeze cycle. Oh yeah, this is the follow-up. This is after 1 month, 3 months, 6 months, 12 months, 24 months. So cryo is ideal for treatment of central lesions. 36 months. Another case, patient 57 years, retroperitoneal leiomyosarcoma, got mets in the lung and bone, for which radiotherapy. 5 years later, there are lung and liver metastases, and we decided in the MDT to treat them both in the same session. So we did a cryo of the lung and a microwave of the liver. We'll now show you the lesion. Again, very central lesion. It's next to the bronchus. We put in 3 ice force needles and 1 below the bronchus to extend the ice all the way to the other side. This is CT from the third freezing cycle. Sometimes you don't see the ice very well, but if you will scan 10 minutes after thawing and taking out the needles, you will see very well the treated area. But this is after removing of the cryo needles. You see a very big area of edema, blood. Follow up, 1 month, 3 months, 6 months, 9 months, 12 months. So with central locations, so it's the most important thing is you can treat them. You still have a bigger chance of developing a fistula or hemoptysis or long-lasting coughing. So you should really discuss it with the patient on the outpatient clinic. This patient had like 3 months of coughing problems, and after that it stopped without antibiotics. This is 22 months. Case 4, patient 68 years old, colorectal carcinoma. Well, 8 years later, local recurrence, and 11 years later, 4 lung metastases. Oh, these decided to do. There were 2 lesions in both lungs. The right lung would get radiotherapy, and the left lung cryo. So we have 1 lesion here, 8 millimeters, very small and central. This one is 10 millimeters and is in an ideal position for a lot of treatments, cryo, RFA, microwave. If you look at this article, you would suspect that the vagus, nervus vagus or nervus phrenic nerve would be in this area. So what we did, you don't want to freeze the mediastinum, so we put in 4 needles, and this needle over here, the more lateral central needle, we used a stick freeze. So we stick this lesion, and then we started making an iatrogenic pneumothorax, and then moving the lesion away, and then putting the other needle, sticking the other needle, and then putting the other needle deeper. So this way you can stick lesions and displace them, so you have a safer treatment. After that, we put a pigtail catheter in, and this is after removing of the needles. She went home the next day, and this is the follow-up after 1 month. The other follow-up, I still don't have them. Another case, 64 years old lady with a thymoma, already got resection and radiotherapy, and got a parectomy 1 year later for mets. 8 years later, again, pleural metastasis on both sides. And in the MDT, well, they said, well, right-sided, give her right-sided partial pleurectomy and left-sided cryo. Here you can see the lesion nearby the ribs. We treated the lesion with 4 ice force needles. And what you see is you see this is the ice barrier, and it's extending really to the skin. So it's important to take care of the skin. You can do a hydrodissection under the skin, or put a glove with warm water. And I always monitor the skin with the ultrasound. You can see the ice ball perfectly, and then you know if you have to put the percentage of freezing lower to get a smaller ice ball, or to give more hydrodissection. What's important though is with these patients is that you need to discuss in the outpatient clinic that they can develop a lot of pain, neurogenic pain from the nerve that you will treat. That's the next to the rib, and a lot of these patients, well, they will get hyperesthesia or hyposthesia for a couple of months, and they will get painkillers for it, and after that it will most of them resolve. This is follow-up 1 month, 6 months, and after 11 months. So for pleural lesions also, cryo is ideal. You can treat the central lesions and pleural lesions, which you would normally not treat with RFA or microwave. Thank you for your attention. Are there any questions?
Thank you
Really
very
nice
much for the
presentation.
presentation. Nice presentation.
Incredible presentation, Tarik. I really like it. I think you already mentioned it, but it will be cool to summarize, like, in which situations do you prefer cryoablation, RFA, or microwave? In which lesions do you use any of these techniques?
For central lesions or pleural lesions or subpleural lesions, I will go for cryo. If the lesions are centrally located in the lung, I go for RFA. But I've had, we had a long time that we only had cryo, so I did a lot of cryo. But now I also use RFA. Microwave, I don't use it that often in the lungs. We use it in a lot of other locations, but not in the lungs. I've used it maybe a couple of times for you say subsolid lesions that I wanted to be a little bit more aggressive because I did not know how far the lesion was extending. But I think for now, I will only use cryo or RFA. And then we use the Levine needle. That's like the umbrella shaped needle.
And any limits on the number of probes that you can use in the lung for cryoablation?
Well, technically there are no limits, but well, if you start treating bigger and bigger lesions, the chance of getting permanent pneumothorax or bleeding will get bigger. So I think the biggest I have treated is maybe 4.5, but I wouldn't recommend to do that.
And one, I think is very important, like any recommendations for some of the interventional radiologists that are studying their clinic and using cryoablation, like starting with smaller lesions maybe, or with really easy lesions first. What are your recommendations for people starting doing lung cryoablation?
Yeah, that's a very good question. Thank you for that. What I should do is I would get some good articles. First, go talking with the surgeons, the radiotherapists, and everybody involved in the MDT. Because, well, in the beginning, they won't like it that you will be sitting there and say, well, I can cryo that. I can also treat this. And focus on the added value. So doing a biopsy together with an ablation. Because, I mean, we do a lot of lung biopsies, but it's a procedure with big complications, and for patients also, it's not very nice. A lot of patients have pain or they are very scared, and now you can just give them, do the biopsy and everything under anesthesia. So that's a way to sell it. Furthermore, I think in the beginning, the problem will be they won't give you the easy cases. That's a lot of, that's a problem. They will go to radiotherapy, or even the surgeons will try to operate it, what doesn't make sense. But so sometimes you will have to do something more difficult, and yeah, try to do your best. And if you do it, deliver a good job, then we'll give you more patience.
Yeah, that's for sure. And I invite all the people in that are watching us to send his question. Tarik is amazing. It's a really nice intervention. So this is an amazing opportunity to learn something, not just about cryoablation alone, but just about any ablation alone also, I think. And so Tarik, how do you sell your procedure to the surgeons and or to all the MDT? Because I think that is the main thing. Like, you know, try to convince them that this is an effective procedure for this kind of patients is sometimes really difficult for us. Yeah. So
I think it's
how is your approach? What is your approach with the MDT?
Well, I think what I said, you have to discuss it up front. Start to know your colleagues, because we need to help each other in the hospital. You know, we help the surgeons a lot with all their complications, putting in drains, etc., bleedings. So for me, it does make sense. It's giving and taking, and but you will. When we started going to the MDT, we just went there and started saying, well, I can do a cryo, or let me ablate this. And well, we got a lot of, how do you say, people were not very nice to us. They were like, what's the evidence? So yeah, why are you telling this? It doesn't make sense, stuff like that. So I think it's important to share the data which is available upfront with them, so they know, well, okay, these guys know what they are talking about, and I know your numbers in the MDT. If they will say, well, what's the evidence for that? That you can tell them what the evidence is, even if it's retrospective or whatever, but that you know the data.
Oh,
this will really
now
help.
we have to do important papers, the Eclipse paper and the Soltis paper that shows that it is a very good technique for treating this kind of lesions.
You have a lot of paper for the Eclipse, and yeah, also for the Levine from Thierry de Beer. There are very big series, with a lot of data supporting. And well,
okay. And what do you think about this, about immunotherapy, combining cryoablation with immunotherapy?
Well, I think that's really interesting, because, well, the idea is that with cryo, you get the most circulating cells, which of the tumor in the blood, and that you could get the best combined with immunotherapy. Still, I think for cryo, we haven't seen the real evidence yet, but I think that's the place we need to go, combining with therapies.
Yeah, perfect. Do you have any question, Pilar?
We need big trials for that. That's the problem. And
no, I think you have all the questions.
It's because I admire so much Tarik. He's he's very important in the field, and just I don't know how much to tell you. Yeah, the presentation was really complete. There was all the things that you must know for starting your cryoablation clinic.
However, and if people still have questions later, they can always send me an email or answer that. Or I mean, we must help each other to get
for sure.
to show the hospital that we have the good therapies.
Yeah. I think it's not just in the lung. Cryoablation is really good for bone lesions and also renal lesions. There's a lot of field to explore with cryoablation. You know, that is the future. RFA and microwave are really cool also, but cryoablation is really good for any lesion. So
I think what makes cryo so well also in other parts of for other organs is that you can see the ice ball very well. And well, if you do a microwave, well, you have to do a contrast scan in the liver or whatever to see how big the zone is. And with cryo, you get it you see that very well. And well, eventually it's all about getting the margins and doing good treatment. So when you're sure of your margins, then you can do a good treatment. Patient.
That reminded me that I have a couple of questions regarding the technique. How, every minute, how during the cryoablation, you do a CT for every 5 minutes, every 10 minutes during the cryoablation, I think.
After the first 3 minutes freeze and thaw, I don't do a CT. Okay. I go to the second freeze cycle, and then 5 minutes in the 7-minute freeze, I make a CT to see how the ice ball is.
Do you do a CT?
Sorry?
Okay. No, go ahead. Sorry, Tarik.
Sometimes if I see that there's sinking or the ice ball is too small, I will go for a third cycle if it's still, and then in the third cycle scan after 8 minutes. If I then still have doubts about the size, I'll put in an extra needle.
Okay.
And do again a 10-minute freeze.
What would have you done differently with that case with the little node behind the bigger mass? Put another needle in between the two others?
Yeah, I think the most important thing that there is contact. Okay. You could decide maybe to put to stack the needles cranial caudal and then something like that, or another way to have contact. I think that's the message. Be sure that you have contact with the lesion. And that's maybe for a small satellite lesion like this, maybe it's better than to do a microwave.
Okay.
If you're not sure about getting good contact.
Nice. And your follow-up of these patients, how do you do it? A CT scan?
We do a CT scan after 1 month with and without contrast. After 3 months, we do the same. And after 6 months, we do a PET CT.
PET CT.
And we follow our own patients we have our own outpatient clinic. So we see all our patients. And this is also really important because then you get the feedback about your own procedures. And then you learn a lot.
Do you guys do any long procedures with PET CT guided?
No, we don't do that. I know in Sloan where you are, they do that, but
yeah. It's very crazy. Well, I'm out of questions, I think, for now, and it's been a really good pleasure. Thank you very much for the presentation, Tarik. Gracias a todos.
Guys, for the invitation, it was really nice. And still, if people have questions, they can send me an email.
Yeah, for sure. Thank you very much, everybody. Gracias a todos. Gracias, Pilar, Fede.
Gracias a ti, gracias a todos. Bueno, lo último, antes de irnos, recordar que el día 30 de noviembre tendremos el próximo directo, donde será un directo patrocinado por Boston, donde hablaremos sobre el tratamiento de las trombosis venosas en los distintos sitios. Así que no os lo perdáis, estaros atentos a las redes sociales y al correo electrónico. Bueno, nos vemos en la próxima.